Okay, good evening. Thank you all for being here. Whether you're here for answers, reassurance, or just because someone mentioned it like this. We're diving into all things perimenopause and menopause and women's health because let's face it, we all deserve a little clarity about what's happening to our bodies. We're lucky to have Dr. Kaur here with us. She's not only a brilliant doctor with a degree from the University of Manchester in diplomas in Obstetrics, Gynaecology and Geriatric Medicine, she is also a member of the Australasian Menopause Society. So if anyone can navigate us through these hot flushes and mood swings and everything in between, it's definitely going to be her. So give her a round of applause.
Thank you so much, everybody, for coming on a Friday evening with all of this rain. So this is an area that I'm really passionate about. So I'm really hopeful that I'm going to be able to give you guys some really good information. You may know some of the stuff already. So I'm just going to start really back to basics. It's been a huge learning curve for me as well. I did go to medical school, and I'll be honest with you, probably had about an hour's worth of teaching on perimenopause and menopause. And my area is women's health. And so you can imagine how much I'm seeing and realizing that there was a huge gap in my knowledge. And I'll put my hand up and say, I remember having a patient coming in to see me who said to me, look, I'm really having a tough time. I'm on HRT, I've done lots of research, but I really think I'd benefit from having some testosterone. And I had absolutely no idea how to prescribe it, what benefit it would have, and really felt terrible that I wasn't able to help her. And so that's really where sort of my learning came in, because I thought I wasn't doing the best that I could for women. And so that's kind of what has led me to where we are today. So lots of learning, because, you know, we haven't had very much, as I've said, and I know there's lots of movement now of doctors really hopefully trying to help women. So hopefully you guys will find this helpful, and I'm going to have plenty of time for questions later. So I might need to shimmy up a bit this way. So I'm from the UK, if you couldn't tell from my accent. I trained at the University of Manchester, and I've been a doctor since 2008, so it's about 16 years. And I work at two practices. Oops, oh dear. Oopsie daisy. Right, let's get this going. Okay, so Thursdays and Fridays I'm at Mount Martha Village Clinic, and then Monday, Tuesday, Wednesdays I'm in Bayside in Chelsea Arcade, and I'm very happy to say that Mount Martha is also home. So these are the things that I'm hoping that we'll cover. What actually is perimenopause? What is menopause? Because they can often get very confusing. Certainly when I was sort of reading about this, it was really important to be able to differentiate the two. How do we diagnose it? Because I'm far often hear too many women saying, you know, my doctor said to me that I'm having periods, so therefore I'm not going through the perimenopause. And we'll hopefully work out that's not actually the case. And why is it that we should be concerned about it? What is the big deal about perimenopause and menopause? But we'll find out. And then how do we manage it? So when we're looking at menopause, I'm going to start with that definition first, because I feel it might just be a little bit easier to explain this. So menopause is when we as women have not had a period for 12 months. So that's the diagnosis, and that's usually 45 and above. If you said to me, look, I've not had a period for 12 months, then we can confidently say, look, you've gone through menopause, with a few caveats. What does menopause actually mean? So typically we were told it's when you can't have children anymore, your ovaries stop producing eggs, and so therefore that's it. That's your sort of reproductive age all gone. But it is more than just that. So menopause will happen to all of us. For the vast majority, it will happen naturally. But there's a group of women where they'll be put into what we call surgical menopause. So they've had to have their ovaries removed for whatever reason, cancer, severe endometriosis, and other conditions, and cysts on the ovaries, and there's no way but we have to take them out. So if we're taking out your ovaries, therefore, we're going to put you into menopause, and this can be at a much younger age. The other way that, unfortunately, some people end up being in menopause is certain medications, if they've had to undergo chemotherapy. So the definition for menopause for most of us will be that if we're 45 or above, and we've not had any periods for 12 months. If we're younger than 45, it's a little bit tricky, and I'll come on to that in just a moment. But it is what we call a retrospective diagnosis. So you're not going to know if you're 50 today whether or not you've had your last period. So it's a retrospective diagnosis. I like to think of perimenopause and menopause as a little bit more than just our ovaries have stopped working and now we're not able to have children. The three hormones that we are looking at when we are going through perimenopause and menopause is estrogen, progesterone, and there's some controversy around testosterone, but I have put it in there because I actually do think that that is also involved in this. Now, when we're talking about estrogen, there are different types, and at different stages in our life, we will have different types of estrogen. But the one that we're talking about in perimenopause and menopause is estradiol. That's the one that's the good estrogen for us. So I just want you to remember that. So this is how I now view perimenopause and menopause. Actually, our hormones are becoming less and less. So as I've sort of mentioned to you before, if you're 45 and over, you guys can make the diagnosis. If you've not had a period for 12 months, then you can confidently say, I have gone through menopause. However, if, for example, you've had an endometrial ablation and you don't have periods, or if you've got the Mirena coil in, it can be very difficult to know whether or not you've had your last period or not, because you're not hardly going to get any periods. So in that case, you can actually have a blood test done. So this is menopause, not perimenopause. And the blood test that you would be having done is something called FSH. So this is a chemical that is made in the brain, and when there's not enough of our hormones, it's like it's sending these distress signals to our ovaries. Please make more hormones. And so that level is elevated. So in summary, menopause, most of us can make the diagnosis now. If we're 45 or over, we don't have a Mirena, we haven't had an endometrial ablation. If we've not had a period for 12 months, we can be confident that you've gone through menopause. But if you've got the Mirena or you've had an ablation and we just don't know, then we can do a blood test. Okay, perimenopause. So what is it? How do we diagnose it? So this is the time before we as women will have our final period, and it can be up to 10 years, even longer, before we have our final period. So it is a long stretch. For some women, like I said, it can be longer, and it's the fluctuation, it's the change. We've got a decrease in our hormones. So estrogen, progesterone, and testosterone, though that is controversial. But the caveat is we are still having periods at this point. So I've spoken to some of the ladies here, and they've been told, well, you can't be in perimenopause because you're still having periods. You will still have periods, even if you're in perimenopause. So, but they might be different. They might not be as regular. They might now be becoming slightly irregular, or the flow might be heavier. But the point is that in perimenopause, you will still be having your periods. So to understand better what might be happening in our bodies is these two diagrams sort of hopefully illustrate, I'm not sure how clear that is, but hopefully will illustrate that our hormones are not just working on our ovaries. It's actually what we've got receptors all over in our body, from the brains, in our eyes, our heart, our blood vessels, our joints, our skin, and that's why the symptoms of perimenopause and menopause are so wide and so varied. So often patients, so estrogen, testosterone, they actually are very anti-inflammatory. So they are good for our body. They reduce the risk of heart disease. They help with our memory. It helps with our libido. Our joints are better when we've got these hormones. Our gut microbiome is better. And as well as sort of maintaining our skin, it just feels nicer. And it helps with our nerves. It's a great lubrication for down below, the vulva, the vagina. And very similar with testosterone and progesterone. So what I'm trying to get at is that our hormones affect every part of our body. It's not just, it's about being able to ovulate, and it's not just about fertility, it's about more than that. So I've divided the symptoms that a lot of women will experience into physical symptoms, psychological symptoms, and what we call genitourinary symptoms. And that's quite a mouthful, but I'll explain that to you in a moment. Now, it doesn't mean that you're going to get all of these symptoms, but some of the common ones that I do hear are the hot flushes, the night sweats, that feeling that I've just lost my zest for life. I just have no energy. I'm doing everything that everybody's telling me to do, but I just can't wake up in the morning. I can't do the exercise that I know I'm supposed to do. There may well be some changes in your periods. A lot of women I see in the 40s will come to me and say, look, I've been getting palpitations recently. And that is, and I wasn't aware of this, and it is actually a common symptom of our sort of estrogen levels decreasing. So we can get palpitations. Headaches or migraines, you may not have had them, but you may start to get them. And I've certainly got women who have more migraines than they used to. And the reason for that is the hormones are fluctuating, and that can affect their migraines. Bloating, dizziness, body aches, just generally feeling very stiff when we're waking up in the morning. And I need to do my stretches and just I feel like I'm an 80-year-old woman some mornings when I'm getting up. Hair thinning, lots of skin changes. Now, these symptoms, yeah, we can put them down to perimenopause and menopause, but often if you were to come in to see a doctor, they are going to want to investigate the cause of palpitations because there are lots of other things. So it's not unusual or unreasonable for a doctor to say, look, you've got palpitations, we need to rule out X, Y, and Z. But if everything's coming back normal and you're in the age range for perimenopause, think about, could it be this? This is the one that I think is most distressing, and I will often get lots of women who just are really struggling with their mental health. And it's worrying that quite often our go-to will be, you definitely need antidepressants or anti-anxiety. And I'm not against those medications, but look at the person, and what we get is the information from you. If you said to me, look, I'm normally quite a happy-go-lucky person, I can deal with stress, but now I can't handle things. I used to be able to multitask, and I used to be able to do a lot more than what I can do now. So mood swings, irritability. I hear a lot that poor sleep. Used to be able to sleep all the way through the night. Now I'm waking up at 2, 3 in the morning. I don't know why, and I can't get back to sleep, and it's driving me crazy. Sleep is so, so important for our well-being, and it's really important from a health point of view. It's when our body repairs. Panic attacks, loss of libido, just not interested, poor sleep, and worryingly, a number of women do feel like that there's no end to this and can have suicidal thoughts. And if anybody does, I'm happy to talk to you guys afterwards, but that's how bad it can be. So it should never be downplayed, perimenopause and menopause, because these symptoms are real. Other symptoms, the final category is what we call genitourinary. So to do with our vulval health, our vaginal health. We know that we're more likely to potentially get urinary tract infections because down below, things are just not as supple as they used to be, so they can get drier. The architecture changes down below, so things can look different. Intercourse can be really painful. Well, not surprisingly, you don't want to have intercourse, because if it's painful, who would? So with perimenopause, there's no blood test. And that's the big thing I want to get across to you, is that there's no blood test to say that you are in perimenopause. It's based on symptoms. And there are some really good apps or questionnaires, which I'll show you, that I will often use with my patients, so that they can start tracking their symptoms. Because like I already know, and I was one of those doctors who said, well, you're still having periods, you'll be fine. It's not the case. So if you're still having periods, you can still be perimenopausal. So A blood test, unfortunately, will not confirm it, but we most often will still do blood tests to check for your iron levels, check your vitamin D levels, check your thyroid levels, because there can be other causes for your symptoms. So we must still do those tests, but it's not going to tell me whether you're perimenopausal. This is a questionnaire that I probably use with most of my patients. So it's from the Australasian Menopause Society. It's a list of questions, which I don't think you can see very well, but hot flushes, lightheadedness, I'm just going to stand here, depressive symptoms, irritability, anxiety, mood changes, dryness down below. And what we will normally do is get you to rate them on a scale of 0, 1, 2, or 3. We're just going to see if we can tweak that. And you can either do that before you go in to see your doctor, or normally some doctors will give it to you, will get you to fill it out. That will give us an idea if you've got perimenopause. If you're ticking, whether that's 1, 2, or 3, and it's affecting you, then we need to be discussing what the treatment options are. So Australasian Menopause Society is a paper copy that you can download, and you can work out what your symptoms are. If you scored 0 for everything, probably not likely. The other one, if you haven't heard of, is the Balance app. And this was set up by a doctor in the UK, Dr. Louise Newson, who is a GP that is really, and I've learned a lot from her, who specialises in women's health. So this is a really good app that you can use. It does rely on you inputting data every day, but if that's okay for you guys to do, it's great. It prints a report out at the end. And often my patients will bring that to me so I can actually see what the symptoms are. So just so that we're all on the same page, and the reason I'm repeating it is because it took me a while to understand. So menopause, you've not had a period for 12 months. We don't usually need to diagnose it unless you're under 45 or you've got the Mirena or had an endometrial ablation. Perimenopause, the time that could be 10 years before you have your last period. We don't have a way of diagnosing it, so we go off your symptoms and ruling out any other causes that it could possibly be. So why should we be concerned about it? Because everyone tells us your periods have stopped. Great. The reason is our body now goes from being into an anti-inflammatory state into a pro-inflammatory state. And that's the main reason that I want to sort of empower all of you that are here today, that even if you feel like I've cruised through perimenopause, I didn't have any symptoms, your body is now in a pro-inflammatory state, which means that you're at increased risk of diseases in the future. So heart disease, increased risk of autoimmune conditions. And you might hear of people saying, look, as soon as I turned 40, my body just fell apart. We hear of people being diagnosed with autoimmune conditions in their 40s. So that's why it's really important that we know about it so that we can actually do something about it. So these are some of the changes that can happen. These are some of the longer term consequences. We are all living longer. So we're going to be spending about a third of our lives perimenopause and menopause. That's a big chunk of our life. So we know there's increased risk of dementia because of the ways that our brain changes without our hormones. I will hear all the time the weight. I've just gained all of this weight. I have done exactly the same as what I've always done. I haven't changed my diet. I'm exercising as much as I always have, but I'm still gaining weight. What's the reason for that? Now, the fact that our bodies don't have enough estrogen, progesterone, testosterone, the body wants us to have those hormones. So what it does is it changes the composition of our body. So instead of being more protein, muscle-based, it becomes more fat-based, because in our fat cells, the body can make a type of estrogen called estrone, not estradiol, which is the one that is really good for our body, but a different version. And so that's why we start to notice weight gain, particularly around our stomach area, our thighs, and we just feel we're not as strong as we used to be because we're losing a lot of muscle mass, and that's because we don't have as much of our hormones as we used to. Heart disease, our blood pressure can start to go up. There's our good cholesterol and bad cholesterol can change. So we notice our LDL, which is one of our bad cholesterols, or triglycerides, which is another one of our bad cholesterols, can start to go up without us having changed anything. We're at increased risk of heart attacks. We're at an increased risk of stroke. So this is what our body is now sort of changing to. It's not anti-inflammatory, it's not protective because we don't have our hormones. Bone changes. So you'll hear of bone scans, osteoporosis. So our bone density starts to change. So instead of it being really nice and strong, our bones, they start to become weaker. And so if we were to have a slight fall, we're more likely to fracture it. And that paves the way then for lots of other changes to our lifestyle. As I sort of mentioned, sort of getting out of bed, the joints feeling stiffer, we're more likely then to develop arthritis. Bladder changes happen, so we're more likely to have UTIs. And unfortunately, some UTIs can cause what we call sepsis, so where we become very unwell, we need to be admitted to hospital, we need to have very strong antibiotics, and that can happen all because we don't have our hormones. Pelvic floor changes. Often we'll hear women say, yep, coughed the other day, tried to do the trampolining with the kids and a little bit of urine came out. But my pelvic floors were really good. I made sure I did all my exercises that I was meant to do sort of after having the children. And why is it that we start to see these changes? Because of our hormones. So what can we do about it? I'm hoping that you're learning a little bit about what happens to our body. And knowledge really is power. And it's really important for me that I'm conveying that this time, that whether you're in your 20s, what to expect in your mid-30s, 40s, and your 50s. And if you are in your 40s and 50s, knowing this is what's actually happening to my body. So what can I do about it? Because I can't stop it because it's a natural process that's going to happen to all of us. So one of the treatments is hormone replacement therapy. Now in Australia, it's also given the word MHT, menopause hormone therapy. It's not strictly true because you can have it when you're perimenopausal as well. And though there are different types of HRT, every one of you is different. So what I might give yourself might be different to what I will have. The dose that I might need may be different to what anybody else might need. My skin is different and I might need higher doses to get the same effect. And so what I want to be clear on is that everybody's regime, if they were to go on HRT or not, if it was safe, is that one size isn't going to fit all. So really, really important that if you have been started on it and you think, do you know what, it's not the wonder medication that everybody said it was going to be, why not? And it may be that we just don't have the right dose for you, we may not have the right hormones for you. So always question that. There are different ways to give hormone replacement therapy. And when we're talking about it, we're talking about the estrogen, the progesterone, and controversial testosterone. So they can be in the forms of tablets, patches, gels. We don't have the spray here, other countries do. And we've also got vaginal pessaries as well. So I'll start with the benefits of HRT. Going back to what is perimenopause and menopause, it's our hormones are starting to decline. So if I give you back your hormones, it's going to make you feel better, but it's getting the right dose for you and the correct formulation. And there are lots of benefits of taking the HRT. So we know that it can reduce the risk of osteoporosis. And that is one of the first line treatments for women who are postmenopausal and have osteoporosis. If there's no reason not to be, we will often say, look, putting you on HRT might be a really good idea because it will reduce your progression of osteoporosis because it can help reverse it. It can reduce the risk of diabetes. It can reduce the risk of heart disease if, for this particular area, if it started within 10 years of you having your final period. The evidence is not great if you start it after 10 years of your final period from a heart point of view, but there are lots of benefits otherwise. So that's just one caveat. And we know that it can help with clinical depression. So if your depression, anxiety is because your hormones are declining, well, surely it makes sense by giving you back your hormones, you're going to feel better. And that's what the evidence says. So we'll start with estrogen, and we'll start with estradiol. So that's the one that our body, the hormone that's actually good for us. There are different versions of estrogen, and some HRT does not have estradiol, but that's the one that you should be having. So make sure it's containing estradiol. Now, it comes in the form of a patch. It also comes in the form of a gel. So you may have heard that there is a patch shortage at the moment, and common examples are Estroderm, Estradot, and sometimes it's trialing different ones. They're a bit like, I guess, a Band-Aid, where they've got the glue in them is different. So you have to find the one that works for you. Some women love the slightly larger patches, others prefer a much more smaller one, and that works really well for them. So a patch is one option. And then there are two types of gel in Australia that we can use. One is called Estragel and one is called Sandrina, and they work really well. We do have tablet form of HRT, and we've also got what we call vaginal pessary. So I have some women who say, look, it's really painful when I'm having sex. It's really uncomfortable down below. I don't have any of the symptoms and I don't want to take HRT, but I need something for down below. And so we've got just estrogen pessaries that we can use just for down below, and they work really, really well. Might come this way, it might be easier to do. The next one is progesterone. And there are two types. One is synthetic progesterone and one is the natural progesterone. When I was training, it was mainly the synthetic progesterone that we used to give. So it's not the same as what our own body makes. It's similar, but it doesn't give you all those added benefits. So I now prescribe only the natural progesterone. And if you have done any little bit of reading, or if any of you are on HRT, it may also be described as body identical or micronized progesterone. So if you're going to be on HRT, most of the women that I talk to, I'm going to be putting them on body identical. I'm not giving them synthetic hormones. This progesterone here, the body identical one, has a name. It's called Prometrium here in Australia, and it's usually given as a tablet that we will take by mouth. Now, someone will say to me, look, when I was on the pill, I couldn't tolerate it. My moods were all over the place. And I'm really worried about starting HRT. And I can say confidently that the pill was synthetic, whereas the HRT, depending on what version you have, is body identical. And so you are much less likely to get those same issues, because all I'm doing is giving you back your hormones in the same manner. Occasionally, women are very, very sensitive to progesterone. It can make their moods worse. So what we might do is give it to them vaginally instead. So what I'm trying to say is that if you do have any side effects, talk to your doctor about it, or talk to somebody who understands hormone so can give it to you in a way that it still does what it needs to do without those side effects. Okay. So the body identical progesterone, or the micronized progesterone, is made from the wild plant yam. It's a very tiny particle, and it's the same molecular structure as what our own bodies make, so progesterone. So that's why it's body identical. So if I think of a lock and a key, and I've got a synthetic progesterone and I've got a body identical progesterone, the synthetic one, you can put it in the key and it might turn a little bit, but with a body identical one, it will go into the lock, you turn it, and it will unlock all of the added benefits that you get from it. So that's how I view it, and it's the safer way of giving it. We've got testosterone, and in Australia at the moment, it's licensed if you have gone through menopause. It's not licensed if you're perimenopause. We're lucky enough that we do have one that is designed for women, and it comes in the form of a gel. At the moment, and I'm hoping this will change, it's licensed if you have severe sexual dysfunction. It's affecting your day-to-day. You've got significant reduction in libido, and it's really affecting your mental health. Now, my views on that, I'm happy to discuss one-to-one, but with testosterone at the moment, the license is if you're postmenopausal. But I know a lot of us will prescribe it off-label because some women do benefit from having testosterone, but the studies we just don't have to fully support that. But I know from when we've tried testosterone, it's been the missing part of the puzzle, and it's really, really helped them from a libido point of view, from a concentration point of view. But the evidence from all the studies that we do at the moment don't fully support that. But I know that when I've had patients on it, they've said that's been the missing part for them. Okay. Now, certainly when I was training to be a doctor, these were the headlines that I was reading about HRT. It causes breast cancer. And so many women stopped it. And so I just want to take a few minutes, hopefully, to try and summarize what all of this was about. So in America, HRT was being used in the 80s. And it was started on women who had just had their final period, and they wanted to see, okay, what benefits are women getting from it? And it's what they call a prospective study. And they found that actually women felt really good. They seemed to have less heart disease. They seemed to have better bone health. But in medicine, that's not the strongest way of getting evidence to prove that HRT is actually really good for us. So what they did was that this huge study was set up called the Women's Health Initiative. And what they wanted to do was make it fair. So it's called a randomized control. So what they did was they had a group of women who took estrogen and a group of women who took estrogen and progesterone. Now, the group of women who took just estrogen didn't need progesterone because they'd had their womb removed. And so then you've got two sides of this study. And the women that were set up to do this were in their 50s all the way up to their 70s. Excuse me. I'm just going to have a drink of water. So 3 years into this really big study, they were noticing that there was an increase of breast cancer. And this got out into the media. And so the trial was partly stopped. And the media are not statisticians, in my opinion. And so, in summary, what the headlines were that if you take HRT, you're going to get breast cancer. And in fact, it's going to double the risk of your breast cancer. And so doctors like me were like, no way am I prescribing this medication. And a lot of women stopped it. Now, a few years later, when they went back and looked at this, because they thought, hang on a minute, in the 80s, when we were giving women HRT, they actually felt really, really good. So how is it that this evidence doesn't seem to match up? Well, the average age of the woman for a start that this study was based on was 63. So this was 13 years after they had gone through menopause. So that's the first caveat. The second is that actually the women that were taking estrogen alone did not have an increased risk of breast cancer. And what they only realized later was that the women who took HRT with the synthetic progesterone and the synthetic estrogen, they were the ones that had very, very slightly increased risk of breast cancer. And when I'm talking slightly, I mean 4 out of 1,000 cases. So that grossly was exaggerated, that it doubled the number of breast cancer cases. The HRT that was used in this study was not the HRT most of us will prescribe today. So there is a difference. That was the synthetic HRT. And actually, the estrogen was from pregnant horses' urine. Yeah. And we were giving that for a long time. And the progesterone was a synthetic progesterone called medroxyprogesterone acetate. So this was, in very simplistic term, in a nutshell, what the WHO study was, and actually misinterpreted the actual information. just bear with me. I'm just going to log in and put my password in. Bingo. Okay, now where have I put my clicker? There we go. Okay. So this is all the information that we went off as doctors, and so that is why, and still today, many of us won't prescribe HRT. But when we go back, if we look at the evidence, the age at which the medication was started, and also the type of HRT that was used. Not all HRT is the same, but we always seem to revert back to this study. And these are the facts that we've talked about, is that estrogen alone didn't increase the risk of breast cancer, and estrogen and synthetic progesterone, there was an additional 4 cases of breast cancer per 1,000 women who were taking it. So I will often use this chart because breast cancer, unfortunately, yes, does happen. And we know a lot of women, I'm sure everybody knows a woman that has had breast cancer. So I just wanted to take a couple of minutes just to put things in perspective. So between the ages of 50 and 59, 23 women will get breast cancer. That's with them not being on HRT. That is what we call our background risk. That's the statistics. Now, if I have a woman who is taking HRT, the synthetic HRT, then they will have an additional 4 cases of breast cancer. If I've got a woman who doesn't have their womb and so doesn't need the progesterone necessarily, they actually have 4 fewer cases of breast cancer. And there is no additional cases of breast cancer in women who take estrogen and body identical progesterone. So the risk is the same as somebody who isn't taking HRT. So those are the facts. So it matters what HRT you're taking. If you're taking the older synthetic type, yes, there is a slightly more increased risk. But if you're taking body identical for up to 5 years, there is no evidence that it increases the risk of breast cancer. Now, this next page, I was shocked at. So how can you guys actually see that or no? Is that clear? Because it isn't clear for me. So what was interesting to me was that smoking significantly increases your risk. I'm just going to stand over here because I think I'm just struggling a little bit. Okay, so
got a young person next.
No, that's okay. I think I can. So drinking alcohol 2 units or more a day significantly increases your risk of breast cancer by 5 additional cases. I was like, wow, okay, that's significant. I didn't know that. If you're smoking, that also increases your risk of breast cancer by 3. But the biggest one was our weight. If I got somebody whose BMI is 30 or more, there is going to be an extra 24 cases of breast cancer. So when you put that into context of HRT and body identical HRT, and actually this is what I tell my patients. I say, look, this is your biggest risk factor for breast cancer, not the HRT. And actually exercise can significantly reduce that. Not everybody, because we know of younger people who do get breast cancer who are super, super fit, but we're sort of talking about us in our older age. So that hopefully puts things into perspective because that was quite new to me. So exercise, we tell everybody exercise as much as you can, but how do you know what exercise to do, how much to do, and so that I can actually see some results? So we know that in perimenopause, menopause, our body composition changes. So we start to lose muscle mass, we're gaining more fat. So how do we combat that? So we're losing muscle mass. So we actually need to be doing weights. If there's one thing that you take away from today is weights. And it's, you know, you can do that at home. You can do it, you know, in a gym, a PT, you can do it here, but weights. And I don't mean doing just your dumbbells and the same exercises, but actually gently getting those weights heavier and heavier. That really, really helps. It improves the muscle mass that we're losing. It improves our body composition, and secondly, it helps with our bones. If any of you have had any bone scans done to check what your bone density is, and we check that it's actually low, one of the big things we're going to say, start doing weights. So don't wait until the bone density goes down, start doing it. And if you're not confident doing it, then make sure you've got somebody who understands women's health. And we don't want you doing 100 kg deadlifts and causing your back to go out. So somebody that is sensible and that understands that it needs to be progressive. And you can do it at home. You can do it on YouTube videos. There's lots out there now where they're just short bursts. So the big thing is that you're doing some weights. Now you can continue doing all of the things. I've got women who love going swimming, people that used to run but just don't find that that's enjoyable anymore, and they're not seeing the results that they want to see with the weight loss. So you can continue doing whatever exercise. I just need you moving your body, whether that's putting on your favorite music and just dancing away to that. That's fine, that's good, that is a great start. But weights is really, really important. And food, what we eat. Lots of women will say to me, what can I eat? What do I eat in perimenopause and menopause? And what I would say is have a varied diet. There is not one thing that I can say to you. If you eat blueberries every day and avocados every day, you're going to be absolutely fine. Our gut microbiome does change in our perimenopause and menopause. So we need to be eating varied fruit. So food, not fruit. So our protein intake, again, when we went back to, we lose a lot of muscle mass. I don't know about you guys, but I can get hungry very, very quickly. And quite often it's just turning to whatever's there, toast, biscuits, just to give me that energy because I'm exhausted by that 2-3 o'clock lull. And actually, most of us don't eat enough protein. It keeps us fuller for longer. It helps with regaining our muscle mass. And if you're doing weights, it's better for us. And like I said, it keeps us fuller for longer. But how much? How do you know how much protein to eat, And some evidence suggests that eating 1 to 1.5 grams per kg of our desired weight is the amount that we should be eating in a day. But you divide that up into your meals and snacks. Fiber, again, really, really important for that. Our gut microbiome is changing. As we do get older, we're more likely to have conditions like diverticulitis or diverticulosis, where our bowels don't work as well, and so we get more constipated, and that can stretch the bowel. And so one of the biggest things that we will say is up your fiber. But again, how much fiber is enough fiber? What if I can't get it from all of my food? So roughly we aim for about 25 grams a day. And I didn't know what 25 grams of fiber was. I was like, what, 5 pieces of fruit and veg? That should be fine. No. There's a really good website called Benefiber. I will quite often ask my patients to go on that, and you can input how much fiber you're getting a day, and it will work out whether you're getting it enough or not. And if you're not, then it's sensible to have a supplement, but only if you can't get it from your food and diet. Added sugars. We all have a sweet tooth, and I just say don't completely rule it out, because then you'll want even more of it. So you can have sweet things, but we need to, if we're thinking about perimenopause and menopause and how our body composition changes, we probably want to make sure that we're not having more than sort of 6 teaspoons a day. That's as a rough idea. That's about 25 grams of sugar. Alcohol, the big one. I'll often hear, ladies say, well, I'm not sleeping. I'm really, tired, I'm really anxious, I'm really depressed. If I have a glass of wine, it really helps me sleep. And the levels just go up. And unfortunately, it's not great for us. So I'm not going to say don't have alcohol, but what I am going to say, we kind of need to keep it to a limit. Because we'll wake up, it's not like when we're in our 30s where we can have a good session and we're still raring, ready to go. The hangover lasts, and it lasts a lot longer than it used to. So I would definitely say, look at reducing that. But obviously we're using that to mask probably the fact that we're not sleeping, the fact that we're not feeling great. So talk to somebody that understands how to treat perimenopause or menopause. So in summary, I'm glad you haven't all gone to sleep, is that the treatment should be individualized for you. what my treatment will be completely different from what your treatment may be, depending upon your symptoms, your background, and your health condition at the time. If you've sailed through perimenopause, fantastic, but it doesn't mean that there's not risks ahead of you in the future. Menopause, body's going into a pro-inflammatory state. We're at increased risk of heart disease, osteoporosis, we're at increased risk of dementia. So we need to be doing something about it. Whether or not you choose HRT or not, that is your choice to make, but as long as you've got the right information about it. Body identical is always the safest. And HRT is not always enough. It's a good part of the treatment, but it won't fix everything. And we should be giving you up-to-date information, not sort of information like the Daily Mail did many years ago that HRT increases the risk of breast cancer. So talk to somebody who understands hormones and menopause. And yeah, I think that's everything that I've kind of got to say at the moment. There may be things that I've missed out, which I'm happy to sort of answer either now or afterwards. Oh, okay, yes. Okay.
This on YouTube, and when people are listening to it, I think that all of our questions will be valid. So just in case you wonder why she's hovering around you when she's asking.
Oh, that's all you had to say?
No. I actually have a question.
Okay, great.
So once you go on HRT,
Yeah.
because I just can't see a downside to it.
Yeah.
Like if it's going to stop me from having like bone density issues and it's going to keep me feeling good and sleeping well, how long do you have to start for 10 years?
So there is no, as long as the benefits continue outweigh the risks, you can be on it for as long as you want to be on it for.
Right.
So there is no end point for it.
Right. And it doesn't change once you go through menopause on the other side. You maybe have to fiddle with how it
Maybe the dosing might need to change because you might find you don't need as much estrogen. That I quite often find. So the dose might change, but if you find that it works for you, you continue being on it. And quite often I might trial somebody off it because they think, oh, I don't think I need it anymore. I'm like, okay, let's wean you off it. Let's see how things are. And most women will say, actually, I prefer to be on it because they just function better with it. Okay. Yes.
Take the mic.
Sorry. With the progesterone, will you, when you go through menopause, will you continue to have a period if you're having it perimenopausal and you're having your HRT, so you get the progesterone because you're still getting your period?
Yeah.
Does it produce a period that is, say, because I know it makes the bleeding with the thickening of the uterus.
Yeah.
What will your period stop?
Yeah.
When you've run out of eggs when you're taking progesterone?
Okay, so when you're perimenopausal, so you're still having periods, we will give you the progesterone in a way that mimics your period. So usually what I'll do is you'll have the progesterone for 2 weeks out of the month, and then you won't have it for the other 2 weeks. And usually when you don't have it for 2 weeks is when you would have your period. Now, when you have, are menopausal, as in you've gone through menopause, so you've had your last period, what we then do is switch the regime. So instead of you being on 2 tablets normally for 2 weeks out of the month, we'll just put you on 1 tablet continuously throughout the month. And if you're, and you won't normally get periods with that then, once you've gone through menopause. You might get it if we initially start you on it because the body's just getting used to the change in hormones. But no, you won't then be having periods even if you're on the progesterone.
Okay.
You don't have to worry about that. Yes.
Another question. Just follow on from that question.
Yes. Yep.
So, based on your information, I'm through menopause.
Yeah. Okay.
I went on HRT.
Yep.
And I bled every day for the 4 months I was on it.
Okay.
Not real good for me. I'm a swim teacher.
Yep.
And so I went off it.
Yeah.
But I still, even though I'm through menopause, I still have a lot of the symptoms.
Yeah.
Is it worth trying again? Like,
Absolutely.
was it just the wrong dose? Or
Could have been the wrong dose, absolutely. And it could have been that your own body was producing some at the time as well, and there just wasn't that balance for it. I'm not sure which particular HRT you were on.
Sandrina and the pro.
Okay, yeah. So you're on the good
Yeah.
stuff, and it may just have been we didn't get your dose right.
Yeah.
So it would certainly, if you're still having symptoms, I would look at restarting it.
Okay.
And if you were still having bleeding, but you then normally what we will do is just check the thickness of the lining of the womb by doing an ultrasound scan, just to make sure that it's not unusually thick, and we need to make some dose adjustments. But it's worth retrying.
Do you have a question?
Yeah.
Oh, okay.
What are the risks of DVT?
Okay, so the risk with DVT depends on the type of HRT that you take. So if you were to take the tablet version of estrogen, so it's normally the estrogens, if you were to take the tablet form of HRT, there is a slight increased risk of DVT. And if you've had a DVT before, we won't prescribe the tablet form of estrogen or synthetic progesterone. So the safest option would be to have it as a patch or gel and having the body identical progesterone, because there's no increased risk of DVT or VTE as we call it.
And what if you're getting periods and then not having them and then getting them, going on the progesterone? Is that going to bring
helps to regulate them? It will help. Sorry, I missed that last bit.
Bring it back to coming back to normal, so you'll get it every month.
So what initially tends to happen is if your periods are sort of erratic all over the place, by giving you the hormones, because you're getting those big dips in the hormones, it will help to stabilize it out. So usually what I tend to find is the periods then become a little bit more regular with the progesterone, and then there'll be a point where they will stop.
Do you know how that one?
You mentioned the Marina earlier. What are your thoughts on using that through perimenopause and into menopause?
Yeah. So Mirena, we'll use it for two different reasons. We'll use it as part of contraception, because you do still need contraception if you're perimenopause, because you can still fall pregnant. So it's great because it can work for that, and it can work as part of the progesterone part of HRT, because it keeps the lining of the womb nice and thin. So if you tolerate the Mirena because you've got heavy periods, you need contraception, and then you actually are perimenopausal, it can work really well because it's sort of killing two birds with one stone. And so, yeah, and there will be women that I would say that that's right for you. Yep, absolutely. Okay.
So, if I have polycystic ovaries, does that mean I'll hit menopause really early if I'm dropping like 30 eggs a month?
No.
No?
There's no reason for that.
Yep. I was wondering, I thought HRT was one tablet, one cream. I didn't realise there's 3 different things for the 3 different hormones.
Mm-hmm.
So how do you know what we all need?
Exactly.
Is that a blood test, or is it just the tick the boxes thing?
Yeah, it's based on symptoms. It really is. So estrogen, progesterone, and controversial testosterone. So if you've got a womb, you definitely need progesterone. And a lot of symptoms are sort of estrogen related. So what I'll commonly do is, let's say I like to be safe. So I would say I put you on the gel, and for the estrogen component, and I put you on the body identical progesterone for that part. And I might say to you, look, I'm going to start you on 2 pumps of the estrogen, and we're going to see how your symptoms go. And because you're still having periods, you're going to take the progesterone 2 weeks out of 4 months to kind of mimic your cycle. And you might say, look, I've got terrible hot flushes, night sweats, I could murder my partner, and I've got no desire for sex. And what you might say to me is, I normally will do a review after 6 to 8 weeks, and you might say, look, my hot flushes are really good, my night sweats are better, but my libido is shocking, and my mood is still terrible. And then what we will do is tweak potentially the estrogen. Now, currently, if you were postmenopausal and you had those symptoms, and you said, look, the reduction in libido is actually really affecting my mental health, we would then look at prescribing testosterone. Okay, so it's all individual.
So further on from that question, I had a hysterectomy at 38, and I only have 1 ovary left.
That was to stop me from going into menopause at that time.
Yeah.
You said earlier that there's a blood test that you can do. I'm 47 now.
Yeah.
A blood test you can do to see if I've
Yeah.
gone through menopause. But I believe, because I could nearly
Tick all of them.
everything that's come out of your mouth is like you're talking directly to me. So how does that work?
Yeah. Okay. So 47. Can I ask? So what I would therefore say in that scenario is that you're 47. If we were to do a blood test and your FSH levels was over a certain number, we might repeat it twice just to make sure over a 6-week period. If they're both over a certain number, that would indicate that you are now post-menopause.
Yeah.
And
I actually think I'm perimenopause.
Perimenopause, yeah. So because you won't be having periods, it can be you won't know.
I have no idea.
Yeah. So blood test for you would be the way that I would say to you if if the blood tests are normal, then I would say you're still perimenopausal.
Yeah.
Oh,
So just a scenario sort of thing. Post-menopause.
Yep.
No periods for 7 years.
Yep.
No symptoms of anything. Do you need to worry about doing anything, or just live life like you're living it?
So in this scenario, I'd probably want to evaluate a few things. So normally what I would do is, we know that, your bone density may be reducing. So I might do a bone scan on you and check to see what your bone density is. So that will give me some information. I would want to know sort of mental health wise how you're doing. I'd want to know, do you have any what we call genitourinary symptoms? So the dryness down below, reoccurring, if you're getting reoccurring urinary tract infections. So if your bone density was great, you don't appear to have any of the genitourinary symptoms, it would be your choice. It might be that
I'm a lucky one.
You are a lucky one. Remember the evidence is that if somebody does go on HRT within the first 10 years of having their last period, that it reduces the risk of heart disease. So it's not clear cut.
No.
And so, I think for you, talk to your doctor and just get a bit more, where are you at in terms of that? But from the sounds of things, it's not, you definitely need to be on HRT.
Yeah, thank you.
Okay.
coming for you, Chrissy.
Thank you. I'm just curious as to how many perimenopausal women do you come across that are actually falling pregnant at 50?
Yeah, it does happen. And that's why we do say you need contraception, because whilst you're still releasing an egg, there is that chance. So it does happen. And there are some women who, by giving them the HRT, their sort of hormones are more regular. It's causing them to, release an egg. And yes, you can still fall pregnant. Oh, yeah. The libido's gone up. So, things are happening. So it can happen. Yeah.
You take it.
Sorry?
Can it say you're pregnant? Can it give a fake period?
Sorry, if you're on HRT and you get pregnant, you can get pregnant on HRT.
Yes, but can you still have a period then when you're having a progesterone?
Yes. Yeah.
And be pregnant?
Yes, because you can have what we call subchorionic hemorrhage, where there's some bleeding. So
Is this like normal, or will it just, you know what I'm saying? Will it like have a, you're not understanding me.
Okay.
It's probably a weird question. But say you have progesterone, which allows you have like your fake period sort of going on.
Yes.
So
you've got your fake period, you've had a withdrawal bleed, and could you still be pregnant? Is that what you're asking? Theoretically, yes. So contraception until you've definitely gone through menopause.
right.
Can you gain weight on HRT?
Theoretically, if we go back to the basics of science, you shouldn't do. But the evidence is not always great to support that. But in my view, and what I've seen, is that I've got women who are on HRT, they feel like they've got energy, they feel like they can do all of the things to improve their health. But if I've got somebody who's on HRT but is still not doing any sort of weights and exercising, then yes, they may continue to gain weight. Yeah. Thank you for being so patient.
It's another Marina question, sorry.
Yeah.
if you are on the marina
Mm.
and you're not getting periods, and you have a blood test, could that blood test be masked by the marina, the progesterone that's given off by
My
the
understanding
marina?
is no. There are, if you're on the pill, yes, it can be masked, but not the marina.
Okay, thank you.
So I've had I have a doctor that I just adore and love, and I had this weird experience where I went in and I was just, she didn't laugh at me, but it was very much like, no, I got given a blood test and got told, but I guess they were testing me for menopause, and I wasn't saying that I was in menopause, and I have my periods.
Yeah.
But so do we have to find a women's health doctor that's working with like the Australasian Menopause Society? Like, how can we?
Yeah.
You're going to be really busy, so like, who else? How else do I find doctors like you?
Yeah. So, yep, Australasian Menopause Society is a good first point of call. I will be opening up more of a menopause appointment clinic, so I think things will change a little bit. But word of mouth, that's one of the biggest things. Going on the, we abbreviate Australasian Menopause Society as AMS, so going on their website, there is a list of doctors on there. Those would be my two sort of bigger ways of finding a doctor who specialises in it, and we're not all the same.
Yeah, you're definitely not.
Yeah, so there's so I think somebody who specialises specifically in perimenopause, menopause is kind of what you're looking at. So word of mouth, to be perfectly honest, or the AMS website. Okay.
Well, I've just spent the last 6 months having every test going to me, and everything's fine. Everything's not fine.
Yeah. Have you brought the question up about HRT? No. Okay. Do you think you've got some knowledge and guts to go in and say now? Okay, good.
I still don't know whether I will get the
answer. So what I would do is.
I've had a colonoscopy, I've had ultrasounds, I've had blood tests,
wow.
I've had everything.
Okay.
And everything's fine, but everything's not fine because I still have everything that you need.
So what I would do is fill out that AMS questionnaire, take it to GP and say, look, can we please try it?
I will find it and I'll put a link in. When I upload onto YouTube, there'll be a link to that form, so you can easily
Do you find men that are in women's health still don't understand it? Yeah. Because I went to mine and he's really good with everything else. And I said, I want to go on to HRT. And it was a blunt, I don't think so with your migraines.
Okay. Again, I think it comes down to education. Like I said, we probably had at most an hour of teaching. Things have changed, things get updated. And so it is a case of learning, and that's what we need. And sometimes, we don't always, general practice is such a wide area that most of us will end up finding an area that really we're passionate about. And so that easily feeds into learning more about it. I mean, I'll drive into work and I'll have my podcast on listening. I'll say, oh, I learned that. That's new, something. So I think it's what somebody's passionate about and wanting to, I guess, educate. But I think things are starting to change. But, like I said, I had a patient and, I wasn't able to answer all of the questions. So went away and really went on this journey. So yes, it is difficult, and I have heard that before. So sometimes it's finding the right practitioner. Okay.
This is a bit of a silly question.
Not at all.
Are you going to have a sort of a similar experience like as your mum or your grandma, or is there a bit of a
genetics?
Yeah.
I'm not sure of what the evidence is, but I will often get women come in and say, I don't want to be like my mum was when she went through menopause.
Because obviously they, like our mums may not have had the education and,
exactly.
Going into the GP and them not knowing. So
sorry?
They all got put on antidepressants back then. So I remember, my mum's not here, but I remember, I thought, I don't want to even go there because it was, I think she didn't have a very
great experience, but I don't know if she had that understanding from
Yeah.
GPs. So
Yeah.
yeah.
Look, I would say it's difficult to say for sure whether it, depending on how your mum went through it, whether you would be the same, but you'll have more knowledge now.
Yeah.
You know what to expect. And so based on that, your experience will be different.
Yeah.
All right.
Any other questions?
You can ask them now while you've got me.
Or forever hold your peace. You don't get to ask again.
Wait around and have a secret question.
You can ask. Yeah.
Thank you everyone for coming. I hope it was just as informative for you as it was for me.
Thank you.
Yes, thank you so
No,
much for
no.
coming. It was wonderful. It's really exciting to meet someone that is like heading their way through something that maybe lots of general practitioners, as I said, and female doctors probably aren't touching on, or just saying, yes, as you said, you're not the right age, or you've got your period and it's just not, So I feel like I have been personally felt like that, where I felt like I wasn't heard and I was a bit shocked, and I thought maybe I'm wrong. And so I'm really glad I feel not wrong now.
So advocate for yourself.
That whole list.
So advocate for yourself and, go in with that questionnaire, go in and say, look, I'm perimenopausal. You're not going to be able to do a blood test that's going to tell me that. It's going to be based on my symptoms, and a bit of, education from you guys. Certainly when I get a patient who comes in and says, well, actually, I think this is what I've got, I take it, I listen to that, because you guys know your own body. So find a practitioner that is able to listen and guide you through it, but you know the information, you know where to get it from, hopefully. So go in there and, just say, look, I think this is what's going on.
So what I'll do is, I think some people were jotting down and trying to take notes in their phone. So I might get your slide.
Yeah.
And then the girls can flick through and, sorry, it was a little bit fuzzy. It's not very good at using my projector. And I'll also find the link to that questionnaire too, and I'll put it in the YouTube channel, so you've got to click on it and get to it nice and easily. But yeah, thank you everyone for coming, and thank you very much for
no
spending
problem.
your time.
Thank you. Thanks. Lovely.
Thanks, girls.
Yeah, thanks for coming out.